Hello everybody, I'm Don Counts. Welcome into Fayetteville Public Utilities Channel 6. Glad to have you here on the program. Today we're going to be talking about orthopedics, and we're going to be talking about the Lincoln Medical Group Orthopedic Associates, and we have Robert A. Beasley, Dr. Robert Beasley. Good to see you. Glad to have you here.
Thank you. Glad to be here.
Yeah, I got to see a presentation from Dr. Beasley at Rotary a few weeks ago, and it was fascinating, and I had to call Katie Stovall as soon as I could to make sure we could make this happen, because there's so many people that have shoulder problems, hip problems, and today we're going to be talking about knee problems. But first of all, tell everybody a little bit about yourself. You've been doing this a long time, and if I was going to pick one, I would want somebody who had been doing it for a while.
Well, I've been in practice for 36 years. I went to Harding College and got my degree in math.
Oh.
And then I went to University of Tennessee Medical School and ended up doing a residency at the Campbell Clinic, which is in Memphis also. It's the University of Tennessee Orthopedic Training Program. And then I went to Cleveland, Tennessee, where I practiced for 27 years before I came to Tullahoma for about 10. And now Russ Spray is the CEO, the past CEO, and now the new CEO of Lincoln County Medical Center, and so he hired me to come over here and do orthopedics when Dr. Greganius left.
Oh, yeah.
And so Dr. Greganius left, and I came in about a month later, and I've been here for about 2 months now.
Well, we like Russ Spray. He's a local boy, done well, and we're proud he's back and taking care of the hospital, and we're proud he hired you. With your experience in orthopedics, it's amazing what all the things have changed over the years since you first started. I can't even imagine where you started.
Well, they started doing total joint replacements in earnest in the 50s.
Oh.
They started out with total hips, and total hips were pioneered and came to be on a firm footing probably about 10 to 15 years before total knees began to be done in large numbers. And the total knee has evolved a lot since about the 60s and 70s when it was being done in large numbers. When I was a resident in the 70s, we were afraid of total knees, and they were fairly different from the way they are now. Through the years, total knees have come to be more and more alike. That is, if you were to look at the total knees that are made by different companies, you would find that they have converged into sort of a single design, no matter what company makes them. Mm-hmm. And so they've worked out many of the details that make total knees work as well as they do now. And so changes have been made in the metallurgy of them, and above all in the quality and durability of the polyethylene that we put into a knee now.
When you talk about the knee, the thing that I see in people who have knee problems, many times it's from old sports injuries. Is that still what you see, or what do you see?
We do see them. I saw a guy just a couple of days ago that had an ACL reconstruction years ago. Mm-hmm. He had his metal interference screw in, had a good outcome from his ACL reconstruction, but he had a worn out knee.
No.
And so we see sports injuries and tibial plateau fractures, meniscal injuries, people that have had a meniscectomy, and now they've worn out their medial compartment.
I got you. What was the meniscectomy?
The meniscus, right.
Yeah.
That's what we call the cartilage in the knee. It's a little flap of gristle-like tissue that lines the periphery of the joint. and acts as sort of a shock absorber. And when it's removed, many times the knee will excuse me, undergo degenerative changes over several years' time, and people will eventually have to have a total knee after that's done.
I think you said there's a lot of people with knee problems, but you know, and as friends of mine who have knee issues, what do you see? What do you tell them when they first come in? What's the first thing you do? I mean, some people have lived with it for years, as you know, and you probably have heard these stories, and just are scared of surgery. And what's some of the processes that you start with?
Well, we start trying to figure out what caused the problem. What is the problem? We make an X-ray, and so there will be people who have just inflammatory problems. They just have an overuse or inflammatory problem, but don't have a structural problem in their knee. And then there will be people that have had an injury. They may have a torn cartilage. They may have damaged the articular surface by a twisting injury. And then there will be people that have arthritic problems. And with all of these different types of problem, you try to determine where are they in the trajectory of this problem. That is, if a person has arthritis, is that person having the beginning symptoms of arthritis, or does that person have an end-stage arthritic problem? And so wherever a person is, you try to treat the person first, non-operatively, medically. And the simplest thing that a person can do for a knee problem that might not be ready for surgery is you can just back off on your activities. You can take some over-the-counter anti-inflammatory medicines, things like ibuprofen, naproxen, and then there are also prescription anti-inflammatory medications, meloxicam, diclofenac. And of course, there are some that have gone out of usage that we used to use but don't use anymore. And then after that, sometimes people may have an injection into the knee. And there are different types of injections. There's an injection of cortisone that we do for arthritic problems. And then there are preparations that have been devised to try to improve the quality of the shock-absorbing lubricating fluid in the knee joint.
Wow.
And these are called viscosupplementation injections. That's a big word that just means it's for the fluid in the knee.
Wow.
Sometimes people call these rooster comb injections. And they're usually given in a series, and they may have some benefit in an arthritic knee also.
Wow.
A person may have an arthroscopy of the knee, which is an operation that's done on an outpatient basis. We usually make 2 or 3 little incisions on the front of the knee and look into the knee with a telescope. And there are things that we can do with small instruments that are also inserted through these small incisions on the front of the knee. And then after oral anti-inflammatory medications and rest, possibly an injection, possibly an arthroscopy. The other thing that we would end up doing in an arthritic knee is to do a total knee replacement.
Let's talk about some of the surgery. Is this where you're actually cutting the knee open? Like I've seen in many times past where a cut is from here to here. Do you still do that?
Yes, that's what we do when we do a total knee replacement. A total knee has a big cut straight down the front of the knee in almost every case.
Okay.
And so it's a big operation. It's done on an inpatient basis in most cases. About 5% of them across the country are done on an outpatient basis. But that's applicable to a fairly small segment of the population. And so by and large, a total knee is an inpatient procedure.
Okay, what about, what's the word when you just put holes in the knee? What's that one
That's
called?
the arthroscopy that I was describing before.
Okay.
We make little holes on the front of the knee, and we have instruments that are sort of the size of a pencil, you might say. And these, we have little telescopes that, where we look at a television screen to do the procedure itself.
Wow.
We're looking at a screen and doing something like this,
Wow.
you see, and so you get used to it. It just becomes second nature.
You probably have better cameras than I've got.
I don't know. I bet yours are pretty good.
Oh, well, I don't know.
But they have improved a lot over the years. The view that we have with an arthroscopy is remarkable. It's like looking into an aquarium, you know. You see very clearly and are able to look at all different, in the different recesses of the knee. And we put a little probe in and feel things and pull on it to see how tight it is and that type of thing.
Oh, wow, wow. That, let's talk about the surgery in general, the actual surgery room real quick. Tell us, besides the patient, who all's in there with you?
If you do a total knee, let's just take as an example
total knee.
of the total knee. You have an anesthetist at the head of the table.
So you got somebody here putting them asleep.
That's correct.
Okay.
They go to sleep, they have a spinal, they have an epidural, they have a block, something like that.
Gotcha.
And that's all done by the anesthetist. And then in addition to the doctor, you have usually someone at a table of instruments that is passing the instruments. And that person is a scrub tech. And then there may be assistants who stand at the table with the doctor and hold retractors in order to expose the operative field so that you can see what you're doing and do it. And they do various things that are sort of like holding a retractor.
I got you.
And there may be, on a total knee, there would be 2 additional assistants standing at the table and holding retractors with me, and then the person at the table that's passing the instruments. And then also in the room there's a circulator, and the circulator is a nurse who is bringing things that you may need. She's giving you more irrigation if you need it.
Gotcha.
And so if you say, hey, I think I need this,
Right.
then she'll go get it.
She's the gopher.
That's right.
Very good.
Don't tell her I said that, though.
Not a good name. My girls don't like that either.
That's right. Yeah.
That's right.
But she's bringing things that need to be brought.
Very important person.
That's right. She's a very important person.
Just like my girls. Well, let's talk about the surgery itself. Now, there's a couple things here. Let's talk about what you've got here. What are you going to show us here first?
Right.
And then we'll talk about what we're seeing inside after you cut open.
This is what a total knee looks like. And so the total knee itself is put into the bones, and it's put in by shaving small slivers of bone off the end in a precise way, and then replacing those slivers of bone with pieces of metal and plastic to replace the articulating surface of the knee. And that's what this is. If you look at the knee joint itself, it goes back and forth like that. And then the ends of the bones are replaced by a metal piece that looks sort of like this.
Wow.
And then another metal piece on the top of the tibia that looks like this.
Wow.
And that piece has a piece of plastic that is clipped onto the top of it. And so the plastic that's clipped onto the top of the tibial component becomes the tibial articulating surface that is opposed to the femoral articular surface, which is made of metal. And 90% of the femoral components are made of a cobalt chrome molybdenum alloy that is machined to look like that.
Wow.
And we cut the the femur, we do 5 cuts on the femur that are guided by jigs and that change the irregular rounded surface of the femur into a regular geometric surface that fits on the inside of the femoral component that has exactly the same shape.
Oh, wow.
Okay. I've brought a couple of old tibial components that I've removed. One of the major improvements in total knee replacement is the improvement that we've experienced in the polyethylene. And so the polyethylene tibial component is the component that experiences the major portion of the wear in a total knee. And so if a total knee is going to wear out, it's the polyethylene that is going to wear out. And back in the old days, we used to put polyethylene on, and we expected that within about 10 years, this was going to wear out and have to be replaced.
From the constant movement
From
of
the
knee.
constant wear. Right.
And the weight, I'm sure.
And the weight. And so this is a tibial component that I took out many years ago that had probably been in about 10 years. And you can see that in contrast to this very smooth plastic on this tibial component here, this is worn and the surface has broken off in places. And here's another one that looks very much like it. And so these were early pieces of polyethylene that lasted probably about 10 years and then had to be replaced because of polyethylene wear. These were probably removed in the 80s. And then as time went by, the polyethylene improved to the point that we see extremely low rates of wear at this time.
Very good.
It would take several years for polyethylene component to wear as much as 1 millimeter.
Wow.
And so we expect that that the polyethylene that we're putting in now is going to last much longer than the polyethylene that we used to put in.
So when you get through with this surgery, they have a brand new knee.
That's correct. That's right.
Total knee replacement, brand new knee. Now,
It just came out of the package.
just came out of the package. Wow, that's nice to know that that's a possibility. Now, what's the recovery time, and what do you feel like it takes to in this situation?
Most people that have a total knee are in the hospital from 1 to 3 days.
Gotcha.
And there are people that go directly home, and there are people that go to a skilled care facility for their rehab. And most people that go to a skilled care facility are older. They don't have people to take care of them at home.
Right.
And so the skilled care facility will take care of them usually for a few days, up to about 3 weeks, depending on their age and infirmity. And then people are usually able to go home after that.
Yeah, I'm sure during this time it's some physical therapy. You want them moving, I'm assuming.
That's right. They get up and walk the day after their surgery or the day of their surgery.
Wow.
And then they're having physical therapists supervise their rehabilitation. And the big obstacle in total knee replacement is to restore motion. People are trying to get their knee to bend and straighten fully. Wow. And that's what that's the obstacle that total knee replacement patients have, and they're getting by.
Wow. Well, the whole concept of the knee replacement, when you get it there, and let's say, for instance, from the beginning, when they come in to see you, and after the pain is going away quickly, or does it take a while for that to go away?
Well, most people recognize that the pain of their arthritis has been relieved by the total knee replacement early.
Immediately.
But they are having a big operation,
Right.
and that operation causes swelling and stiffness. And so they recognize that they have another type of pain that they have to get over, and that goes away gradually over a period of time that lasts from weeks to months. And we usually tell people that their swelling and stiffness are resolving over several months' time.
Gotcha.
Most people are functioning well within, say, 3 weeks. Within 3 or 4 weeks, many people are able to get out and go to the store and things like that. And they're able to walk well. They're functioning at a high level, but they're still having to exercise their knee to get their motion back, and gradually improving over several months' time.
And that exercise be walking mainly, or what other kind of?
Walking, but also specific exercises to stretch the knee to restore its flexion and extension.
Gotcha. Wow. And you say you see a lot of people with knee problems, and you do that surgery here in Fayetteville.
That's right.
Wow, very good. And if someone has a knee problem that's been bothering them for a while, they just need to call up to the hospital and make an appointment with you, or is there?
That's right.
All right.
That's right.
433-1102 is the number, and that's
Okay.
good, very good for that. On here, you might want to mention the guy with you here, his name.
Okay, this is Ryan Parton. He's a young kid, a good kid that's worked for at least 6 years as a nurse practitioner. I call him a kid because I'm about 30 years older than he is.
I understand.
But he is he's a very reliable person who I'm able to leave in the office. He is able to take care of most of the things that come in, and we work together. He sees my patients, and he works them up and schedules them for surgery. He's able to treat them conservatively, and he and I have the same philosophy and approach to most of these problems. He's got a lot of experience as a nurse practitioner. I think that he was in practice for 6 years in Huntsville before he came here.
Is he involved in the surgeries with you there or not?
He doesn't go to surgery as a rule.
Yeah, that's very good though.
He does go to the hospital and see patients in the hospital.
It's always good to have good people with you.
That's right,
Absolutely.
and he is very good.
Very good. So if somebody's having knee problems, knee situations, or any kind of problems with their bone, you want them to give you a call, and you can help them out.
We'll screen them and see what's wrong with them and help them to the degree that we can.
Very good. Well, we appreciate you talking to us about all the things that you've got going on there. We appreciate the hospital being here. We're proud to have a good hospital like we have, and it takes good people to take care of it, and we appreciate you coming to talk to us about knees. And you know, there's very few people we run into today that don't have some kind of pain somewhere in there, but this situation could help them.
Thank you.
Thank you very much.
Appreciate it.
Thank you. Today we've had Robert Beasley, Dr. Robert Beasley here, the orthopedic surgeon here at the hospital at Lincoln Medical Center. And we appreciate him coming by, talking to us today. Appreciate Katie Stovall for bringing him in here today. And we wish you well while you're in town.
Thank you.
Thank you very much.
I appreciate it.
Thank you for watching Fayetteville Public Utilities Channel 6. I'm Don Counts, and we'll see you back in here next time.